So now we move on to the cervix. Cervical pathology can be divided into precancerous and cancerous lesions. Precancer includes dysplasias, and if the dysplasia involves the entire thickness of the epithelium up to the basement membrane, then it's referred to as a carcinoma in situ. The classification changes to invasive carcinoma when there is invasion past the basement membrane, allowing access to the blood vessels and lymphatics, which can then lead to metastasis. Cervical dysplasia, with characteristic coilocytes, noted on Pap smear, occurs in the setting of human papillomavirus infection. You can see some coilocytes right here and right here. Coilocyte is a buzzword frequently used in the context of HPV, so be sure to keep it in mind. As you compare the normal cervical epithelium on the left and dysplastic cervical epithelium on the right, start at the basement membrane. On top should be nice stratified squamous epithelium. On the right you can see the disorganization and increase in nuclei in the bottom 2/3 of the epithelium. As you compare the normal cervical epithelium on the left and dysplastic cervical epithelium on the right, start at the basement membrane. On top should be nice stratified squamous epithelium. On the right you can see the disorganization and increase in nuclei in the bottom 2/3 of the epithelium. But basically the entire thickness is involved, so this is a CIN3, or a carcinoma in situ. Certain strains of HPV, notably 16 and 18, are responsible for 70% of all cervical cancers, whereas HPV 6 and 11 cause 90% of all benign genital warts and condyloma acuminata. So if you get a patient with HPV 6 or 11 infection, you go down a much different treatment path. Of note, there are now 2 HPV vaccines approved in the US, Gardasil and Cervarix, that protect against HPV 16 and 18, and therefore cervical cancer. In addition, Gardasil also protects against HPV 6 and 11. Risk factors for HPV infection include multiple sexual partners, smoking, early intercourse, and HIV infection. So actually, once you get cervical cancer, one of the more common causes of mortality is renal failure. Why is that? It's actually pretty easy to visualize. The cancer can spread laterally to block the ureters, leading to renal failure. Moving on to the endometrium, we have a condition known as endometritis, which, as you can tell from the name, describes inflammation of the endometrium. I'm sure you're all red, angry, and swollen in anticipation, so I'll explain where it comes from. It's generally associated with retained products of conception following any form of childbirth, death of a fetus, or prolonged presence of a foreign body. This retained material serves as a nest of infection for bacteria from the vagina or the GI tract, leading to abdominal pain, fever, uterine tenderness, menstrual abnormalities, and infertility. It should definitely make an appearance on your differential whenever you see the constellation of symptoms in the setting of recent childbirth, miscarriage, or abortion. Treatment involves use of appropriate antibiotics. Another important and common condition, endometriosis, is a condition where endometrial tissue is found in locations outside of the uterus. This tissue behaves like normal endometrial tissue despite its ectopy, and thus you have cyclic menstrual bleeding from these sites. The most common locations include the ovaries and the cul-de-sac in the peritoneum, otherwise known as the pouch of Douglas. So can you recall from your anatomy where the pouch of Douglas is? It's located between the uterus and the rectum. When you have endometrial tissue implanted there, the patient may have painful defecation during menstruation. When the ectopic endometrial tissue in the ovaries bleeds and clots, they can become enlarged and tender, forming so-called chocolate cysts. This image shows ruptured chocolate cysts in the left ovary of this patient. Typically, the symptoms you're looking for include dysmenorrhea, or painful menses, dyspareunia, or painful intercourse, and infertility. One particular subtype of endometriosis is adenomyosis. Here, you get endometrial tissue embedded in the muscular myometrium of the uterus. The symptoms are pretty much like endometriosis, but because of where the endometrial tissue is, you can also get vaginal pressure, where it feels like the uterus is trying to push out through the vagina, like when you're delivering a baby. Endometrial hyperplasia is abnormal endometrial gland growth that is a direct result of excess estrogen stimulation. This condition is precancerous and needs to be treated, but with what? Well, it's treated most often with progesterone agents, but why is that? Because progesterone tends to balance out estrogen. Endometrial hyperplasia is more common in any state that causes unopposed estrogen, including anovulatory cycles, hormone replacement therapy, polycystic ovarian syndrome, and granulosa cell tumors. In a woman's menstrual cycle, pre-ovulation is associated with an estrogen-dominant state, whereas post-ovulation is associated with a progesterone-dominant state. So as a result, if a woman is having anovulatory cycles, like in polycystic ovarian syndrome, then she does not have the transition from estrogen to progesterone, so estrogen stays unopposed. With hormone replacement therapy, you have a situation where you're receiving exogenous estrogen, and with granulosa tumors, as we'll see when we talk about ovarian stromal cancer, these lesions secrete estrogen. Again, it doesn't matter where it's coming from, all that matters is that you've got a persistently high estrogen state. When endometrial hyperplasia finally becomes adenocarcinoma of the endometrium, it most often presents as postmenopausal vaginal bleeding. If you get a question when the patient is in her 50s or 60s, i.e. postmenopausal, and has new onset vaginal bleeding, you have to think about endometrial cancer since it's the most common gynecological malignancy. This image shows a typical endometrial adenocarcinoma presenting as a polypoid and fungating mass in the body of the uterus. The risk factors for endometrial carcinoma are the same as those for hyperplasia. Prolonged unopposed estrogen. But just as a side note, endometrial cancer actually has by far the best prognosis of all the major gynecological malignancies, better than cervical and ovarian cancer. Can you think of why patients who have never been pregnant, who have early menarche and late menopause, will have increased risk for endometrial cancer? Again, it has to do with the estrogen-progesterone balance. During pregnancy, the predominant hormone is progesterone, so it's protective against endometrial cancer. Early menarche and late menopause extend the reproductive time period when estrogen is high. During premenarche, patients have immature ovaries and have low estrogen, whereas postmenopausal women have non-functional ovaries and also low estrogen. Moving on, it's important to know that the most common type of tumor in females is the leiomyoma, also known as a uterine fibroid. These are benign smooth muscle tumors that are estrogen sensitive. They grow with pregnancy and shrink with menopause, as do the symptoms of extensive fibroid disease, especially pain in that region. As you can see from the image, they look like a ball of muscle. They tend to occur most often in younger women and can cause abnormal uterine bleeding. On histology, they have whorled or twisted patterns of smooth muscle bundles. You can kind of see the whorling here on the gross pathology as well. The word whorl is another good descriptive medical buzzword you'll want to keep in mind in the context of leiomyomas. As I just mentioned, uterine fibroids are benign and they do not lead to leiomyosarcomas, which are bulky, irregular-shaped malignant tumors. Notice in the image the spindle-shaped tumor cells that resemble smooth muscle but include abnormal features such as increased nuclear to cytoplasm ratio, mitotic figures, etc. Remember that leiomyosarcomas are not associated with leiomyomas and are more common in blacks and middle-aged women. These tumors are highly aggressive and often recur when removed. The most common gynecological cancers are endometrial, then ovarian, then cervical. While cervical cancer used to be the most prevalent, the advent of the Pap smear in the 50s, named after the brilliant Greek physician Yorgos Papanikolaou, has allowed doctors to catch and treat cervical precancer, causing the prevalence to drop dramatically, at least in developed countries. In terms of mortality from gynecological cancers, the order from most to least deaths per year is ovarian, then cervical, then endometrial. Ovarian cancer can be really bad, actually, because they are typically silent and asymptomatic until they are at stage 3, at which point they have spread out to the pelvis and generally have a poor prognosis. A couple of other thoughts here. Don't confuse gynecologic cancers with all cancers in women. Remember that in women, the most common cancers are breast, then lung, then colon cancer. In terms of mortality, it's lung, then breast, then colon cancer. So in women, breast cancer is most common, but lung cancer is most deadly.